Well, it's really a pleasure for me to be here today because I think that this region, the Asian region, is at a pivotal moment where decisions that you make in the near future could make the difference between a bigger and growing epidemic or controlling the epidemic. And so it's exciting for me to be here with you and to share information about scaling up PrEP to impact HIV transmission. First, in terms of my disclosures, trials to develop an oral PrEP indication were funded by the public sector with some help from the Bill and Melinda Gates Foundation. Gilead Sciences donated study medication to the study sponsors, and ViiV contracted with Gladstone, one of my employers, to support phase 2 research on long-acting injectable PrEP. And you'll be hearing more about that briefly in my lecture, but Dr. Markowitz is here from New York, who'll be describing more fully the results of our ECLAIR study on long-acting injectable PrEP. So this morning, I'm going to make some comments about PrEP evidence and recommendations. I'm going to describe how demand drives diffusion of PrEP innovations, or at least it has so far. We tend to focus on supply, but it's really demand that triggers providers to want to provide this service. We have emerging evidence that PrEP is having a favorable impact on the HIV epidemic in terms of new transmission. I want to speak specifically about the problem of adherence among youth. Youth carry a disproportionate burden of new HIV transmissions, and adherence requires a youth-oriented focus. I will mention very briefly long-acting injectables because you'll hear the full story from the leader in this field, Marty Markowitz, and then I'll describe on-demand dosing and its promise and evidence. So in September 2015, the World Health Organization issued a broad recommendation that said, and I think the wording is important, oral PrEP containing tenofovir disoproxil fumarate should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination prevention approaches. They made this as a strong recommendation based on high-quality evidence after a systematic grade analysis of evidence published or presented through May 2015. This was the most comprehensive systematic review of PrEP evidence that I have ever seen because it included safety, effectiveness, feasibility, acceptability, costs, cost-effectiveness, and ethics. To be sure, the wording of this recommendation is important. They've moved away from key populations to focus at everyone at substantial risk, leaving that to local epidemiologic authorities to understand how best to deploy PrEP. This is just a graph describing the evidence of efficacy in PrEP. You won't need to read every word of this, although it is published just a few weeks ago in AIDS by Virginia Fauner et al. Basically, there is an abundance of evidence involving more than 17,000 research participants who were involved in 12 different trials, most of them placebo-controlled and blinded randomized trials. And these studies, when taken together, showed that PrEP is effective in men and women. It's effective regardless of the mode of transmission, whether it be rectal or vaginal and penile. It's effective in young people as well as old people, or older people, more than 25 years. Interestingly, it's effective whether tenofovir is used as a single agent or whether the combination of emtricitabine and tenofovir is used. And it was effective as a daily dosing strategy as well as an intermittent dosing strategy, which we'll describe in more detail, called on-demand dosing. The only interaction in the effectiveness data is adherence. PrEP is only effective when used, and there's a clear dose response between studies that had high adherence, moderate adherence, or low adherence. And this is described in this figure in which we plot the reduction in HIV risk on the y-axis against the percent of people in the active arm of the trials who had detectable drug. You can see as you plot the studies, the circles indicate the amount of information derived from the study, the number of seroconverters. You can see that there's really a one-to-one correspondence between the proportion of people in the active arm who had detectable drug and protection. such that in people who had detectable drug, risk of acquiring HIV is markedly decreased by over 90%. I just wanted to highlight that 4 of these studies had arms that evaluated tenofovir as a single agent, and they include the Bangkok TDF study, the Partners PrEP study, a small US CDC safety study done in men who have sex with men, and the VOICE trial, and that the TDF-only arms gave a risk reduction that was comparable to risk reduction seen with co-formulated emtricitabine and tenofovir disoproxil fumarate. Safety is a major concern in the prevention field. People who are reluctant to start PrEP, just as people who are reluctant to start treatment, often cite concerns about safety. One of the remarkable findings from PrEP research is that emtricitabine and tenofovir, or tenofovir alone, are astonishingly safe medications. This is a forest plot looking at all adverse events across all studies and grade 3 and 4 adverse events. You can see really there's not even a trend to suggest that the active arms were more hazardous than the placebo arms. This is a message that we would do well to send to people who are considering PrEP, as well as to people who may be reluctant to start combination therapies for their HIV infection. Modern therapy for HIV is safer than people know. There are specific safety concerns with tenofovir disoproxil fumarate. They've been addressed in intensive analyses from several of the studies. We know that these medications are associated with a small but reversible change in estimated creatinine clearance. When the medications are stopped, this is reversed. There's also a small but reversible change in bone mineral density, but no excess in fracture risk. There were no hepatitis B flares or hepatitis B drug resistance. HIV drug resistance was extremely rare and isolated to people who were already HIV infected at the time they started PrEP. There was no difference in contraceptive efficacy or pregnancy outcomes in the studies that involved women of reproductive age. There's actually an interesting commentary in which the authors ask, is emtricitabine tenofovir pre-exposure prophylaxis for prevention of HIV infection safer than aspirin? Jeff Klausner and his colleague calculated the number needed to harm with FTC-TDF PrEP and found that out of 114 PrEP users, there might be one that had dose-limiting nausea, and 96 people were needed to cause unintentional weight loss. And this actually compares favorably with aspirin, which has bleeding and bruising or any gastrointestinal bleeding as major complications. So in fact, it can be argued that TDF PrEP is as safe as aspirin. So since the WHO recommendation in September 2015, we've seen approvals by several countries, including plans to roll out PrEP with public funds. These countries include South Africa, France, Kenya, Canada, and Israel. In addition, there are other countries that have approved the medications for prevention use, including for use as PrEP, but there's not yet a publicly funded program for this service. And these countries include Peru, Switzerland, and Australia. Other countries are actively considering PrEP indications and PrEP service programs. So it's no longer just the United States that's rolling out PrEP. And that was just official approvals of PrEP. There are PrEP demonstration projects in at least 24 countries around the world. This is a dynamic map maintained by the APACC organization based in New York. And you can see that countries around the world are exploring PrEP through small and large-scale demonstration projects. I hope that the next time I speak here, China will be colored orange here. Now, what is happening with PrEP demand? Fine if PrEP is available, but do people really want it, and is anyone really using it? What we found was that after the first evidence of PrEP safety and efficacy became available in late 2010, demand was relatively flat in the United States until late 2013 and 2014. at which point a tipping point in demand was reached, and Gilead Sciences reported a 332% increase in PrEP use over the course of 2014 through their FDA-mandated surveillance. And the U.S. is no longer the only country where we've seen PrEP demand explode. This is information presented, or that will be presented by Don Colby tomorrow, I believe, based at their PrEP 30 service managed by the Thai Red Cross. You can see that, like in the U.S., demand was relatively low to modest for a period of time, but starting in late August 2015, there was really an explosion in PrEP interest and use. What is driving this change, this tipping point? Well, I think that they argue that it was effective communication, a well-known driver of dissemination of innovations. There were online promotions launched that were appealing to men who have sex with men and others at substantial risk. And then APACC organized a regional meeting in which called Preparing Asia for PrEP that really highlighted the opportunity that this new intervention has for controlling the epidemic. So it was really information presented in attractive and fun ways that drove demand to a tipping point. And we see this also in the United States. The latest iteration of PrEP advertising, if you will, or PrEP communications, is being very careful to frame PrEP in the context of people's social, sexual, and reproductive goals. And this is the latest effort led by the AIDS Foundation Chicago and released just in 2016. And what they've done is they've juxtaposed terms that are normally used in HIV prevention, terms like catch and contract and spread and transmit. But they've juxtaposed those terms with socially desirable activities like desire, heat, tingle, and love. So in this series of photos, we have catch desire, contract heat, spread tingle, and transmit love. This is the kind of positive framing of HIV prevention messages that drives demand for prevention services. But I think more than anything, it's been champion PrEP users who have emerged in our environments that have tipped the balance in favor of acceptability of prevention services, including PrEP. And the first I will give credit to is Damon Jacobs, who in November 2012 was the first person I know of to come out and use his own name publicly to say that he was a PrEP user and he was proud to use PrEP because it was a way to protect himself, to protect his boyfriend and his boyfriends at the time, and to protect his community. And he continues to lead a social media site on Facebook that has 14,000 members, many of them PrEP users, who use that social media site to share practical information and real information about safety and efficacy that they have a hard time getting from their healthcare providers. But it's not just Damon Jacobs. Batambili, a sex worker in Zimbabwe, told the WHO in a meeting last March that PrEP has empowered her. For the first time ever, she has control of her HIV risk. She doesn't have to rely on her clients to use condoms or to tell the truth about their HIV status or their treatment status. She can control her own HIV risk, and that has empowered her in all aspects of her lives. She can now plan for a life without HIV. She's planning a career. She's planning to go back to school for the first time ever. Najee Dawkins, a young man in Oakland, also talks about how PrEP has empowered him as a young black man who has sex with men. And then we've even had publicly elected officials like Scott Wiener who have come out of the PrEP closet. So you don't need very many champion PrEP users, but I think that you do need one. You need one in your region who's willing to speak out, use their own name, and to make clear that the choice to use PrEP to protect oneself from HIV is a choice that someone can be proud of. So I wanted to focus on my hometown just for a little bit and talk about the dissemination of PrEP innovations in San Francisco, California. You can see that like all dissemination of innovation, we expect PrEP to disseminate along a pattern that goes from innovators to early adopters to an early majority, a late majority, and finally laggards, and that this dissemination is expected to occur over time. Albert Liu, my colleague at the San Francisco Department of Public Health, published in 2013 that the innovators in the PrEP field who had participated in clinical trials were starting to pass the concept off to early adopters in large-scale clinical practices, including a reproductive health clinic. I presented in early 2015 information that early adopters had pretty much taken up PrEP, such that 10 to 15% of gay men in San Francisco were already on PrEP by the end of 2014. And Stephanie Cohen, my colleague at the Sexual Health Clinic in San Francisco, found that PrEP use had doubled again in 2015. So in the United States, it does appear that PrEP use is doubling every year since 2013. Who is using PrEP? One of the remarkable factors of PrEP demand has been that the people who benefit the most from PrEP search it out. It's actually much easier to market, if you will, PrEP than condoms, where we've struggled to get people at highest risk to adopt condoms. In the case of PrEP, just offering PrEP brings people out who we would not otherwise see in our prevention services. And here we see information from 3 different surveys done in San Francisco in 2014. A street survey where walk-up interviews were done, a probability sample with a huge amount of rigor called the National Health and Behavior Survey, and a convenience sample of our STD clinic run by the city and county of San Francisco. You can see that all 3 surveys are remarkably concordant in that they show that people who have the most to benefit from PrEP, who have the most condomless anal intercourse partners, are the most likely to take up PrEP, such that by the end of 2014, 63% of men with multiple partners that they were not using condoms with had already taken up PrEP. And again, PrEP use doubled again in 2015. So this is a key factor that PrEP, we struggle to think, well, how are we going to find people at substantial risk and how are we going to make them take PrEP? In fact, our experience from clinical practice has been the opposite. They find us, and the people who are at highest risk for acquiring HIV are most likely to take up PrEP, most likely to be retained in care, and most likely to be adherent. And this is having a favorable impact in San Francisco. This is the number of new HIV diagnoses made every year from 2006 to 2014. You can see there's been a steady decline, but it was stubbornly stable, the number of new infections from about 2008 to 2012. And then in the PrEP era, as demand and use of PrEP exploded, we've seen plummeting new infection rates. We don't yet have information from 2015, but our testing centers are telling us that the results will be favorable again. I wanted to highlight one of our pioneering PrEP practices, the Magnet Sexual Health Services, run by the San Francisco AIDS Foundation. This is a community-based organization that's funded through government contracts and philanthropy. Its first PrEP client was started on PrEP in November 2014, and since then, more than 1,000 have started PrEP. There's no charge to the client. Prescriptions are filled by public and private insurance or Gilead-sponsored assistance programs. The clinic is entirely directed and staffed by nurse practitioners. We use point-of-care creatinine and HIV antibody testing that expedites the same-day start of PEP or PrEP, so that people walking in for the first time will walk out with an effective prevention strategy. Our clientele are racially and ethnically diverse, and there's been no HIV infections in the PrEP cohort compared to 47 infections among people who did not have access to PrEP in early 2014 and 15. I also wanted to highlight another model which is similar in many ways. The PrEP 30 at the Thai Red Cross has a VCT and ART treatment center which decided to offer PrEP using their existing facilities. And Don Colby will be telling you more about this tomorrow, I believe, and he provided this slide kindly. A simple protocol was developed that allowed counselors to screen at-risk clients, introduce the concept of PrEP, and refer clients to a doctor if PrEP is indicated and the client agrees. PrEP is provided at the first visit, just as we do in San Francisco. If the HIV test is negative, the creatinine test is pending, they get a phone number and call the person back if an unexpectedly high creatinine level is found. There isn't government funding for PrEP services yet in Thailand, although the medications are approved for that indication. But they're able to minimize the cost of the service to 30 baht per day, which is equivalent to about $1 per day, which is affordable for many Thai MSM. This is a popular service that we're going to be learning a huge amount from, and Don Colby will show you the minimum list of required elements to start your own PrEP service, and it's a remarkably short list. So I wanted to highlight that PrEP plays well with other interventions. Our counselors tell us that PrEP users develop a deeper counseling relationship over the course of multiple visits over a year. It also helps that the counselor and the client end up planning for sex. It enables conversations. But in addition, there's access to STI testing and treatment. But in particular, PrEP is also enabling treatment in several ways. One, there's less HIV infection that needs treatment. People see that ARVs are safe, so that folks living with HIV or hesitant to start therapy may jump on the opportunity now that their friends who are HIV uninfected are also using the same medications. ARVs are no longer associated with HIV, which decreases stigma. PrEP is motivating HIV testing and earlier diagnosis, which enables treatment. And PrEP is also building broader constituencies for HIV programs. And PrEP distributes responsibility for prevention. It's no longer exclusively the requirement of the HIV positive person to get themselves treated, to get themselves tested, to disclose, to use condoms. Now there's shared responsibility for prevention. And that's undermining HIV stigma, undermining criminalization, and engaging and empowering seronegative people. PrEP is fostering agency and empowerment. And I think that one of the ways it does this is it allows sex without fear. Carl Strode, age 23, told a reporter for The Independent that PrEP would allow me to have sex without fear for the first time in my life. It would remove that month-long hangover of psychological anguish after sex, worrying about whether or not I might have put myself at risk for HIV and looking for the slightest sign. The entire gay community is affected by this kind of anguish, and it only fuels the epidemic because when people feel anxious, they don't talk about it. And so these anecdotes and qualitative research, which has now been published, led me to reread some of the research that led to the theory of risk compensation, which we talk about in HIV medicine, but I don't think that we've all had a chance to study the original research. And what I discovered that one of the key findings from driving safety was that belief in future value, much more than perception of risk, fosters safer driving behavior and more durable changes in safer driving behavior. And it struck me that this benefit of PrEP is now transforming HIV prevention, because PrEP and PrEP users are allowing people to imagine a future free of HIV. They're given an opportunity and encouraged to plan for sex and for meeting their sexual goals. They're given control over their own risk, and they're given pleasure. And these are all the features that were associated, and particularly pleasure was a feature that was associated with safer driving behavior. People who are having a good time driving drive safer. So I think that we need to learn how PrEP might have a durable effect leading to safer behavior. Now, I'm not quibbling with the emerging evidence that some PrEP users will choose to stop using condoms. But as they do that, they also become more aware of sexual risks, and they become more open to discussing syphilis, gonorrhea, hepatitis C infection as potential risks now that their overwhelming fear of HIV has been managed and put into the control of their own hands. So one particular challenge with PrEP is adherence among young people who carry a disproportionate burden of HIV acquisition. This is data from the Adolescent Trials Network 110 study that involved 18 to 22-year-old MSM. They studied PrEP use and adherence using dried blood spots, which I think is a state-of-the-art biomarker for long-term PrEP use. And you can see that the green and yellow portions of these bars indicate effective PrEP use that would expected to decrease HIV risk by 86 to 99%. But there's over time, after PrEP is started, there's a growing subgroup of young men who do not use PrEP at all, and the fraction of people using PrEP effectively goes below 50% at week 48. So adherence to PrEP is a challenge for young people, as it is a challenge for people living with HIV who are using treatment. So there's a blog that was just published in the Huffington Post that I thought brought together some key opinion leaders regarding how best to make PrEP possible for youth. And they argued for 8 points. One is to rely on existing youth-centered organizations to the extent possible, to provide wraparound services for youth, and to listen to youth leadership and involve them in leadership position in your service. Marketing is key. Provision of navigation services to young people is also critically important. They don't know your healthcare system. Also, young people will seek out help in a variety of different places in your clinic, and so you need to make sure that everyone who works in your clinic has an open door and can listen and refer and meet people's needs. Clinics can lead even before governments have time to develop policies that are well suited for young people. Clinical medicine has the privilege of having a broad amount of discretion to provide best practices, and clinics can use that discretion to make things better for youth, even in the absence of public policies that are well suited. Confidentiality laws and policies are key. So I think that we have some principles for promoting and making PrEP use possible for young people. But certainly one promising approach for increasing adherence among young people and others is the prospect for long-acting injectable PrEP. And the ECLAIR study was just presented by Marty Markowitz at the CROI meeting last year. This is my colleague Jeff McConnell showing where the injections are made. And I know that Dr. Markowitz is going to speak about this in detail, but I just wanted to highlight that this information that showed that 62 to 74% of people randomized to the active arm of long-acting cabotegravir preferred to continue that long-acting formulation over oral formulations because it's more convenient. And this is despite the fact that the injections frequently had some injection site soreness, although that was self-limited and lasted only a few days. People do prefer this. It's an attractive option, I think, for both treatment and prevention. So I wanted to end with the concept that risk tends to vary over time. And this is an analysis that we did of the placebo arm in IPREX. Every row here represents one of our placebo arm seroconverters, and the dark orange reflects a quarter or a 12-week period in which unprotected receptive anal intercourse was reported, a high-risk sexual behavior. But the gray bars indicate quarters in which there was no condomless anal intercourse. And you can see a remarkable pattern here that was also seen in the IPERGAY study, that people move in and out of seasons of risk. There are moments of risk that are punctuated by sometimes long periods of safety. So PrEP does not have to be continued lifelong. It has to be used when it's needed the most, during seasons of risk, before and after moments of risk. And I think that we need to move away, just as the WHO has moved away, from thinking of risky people and risky groups, but rather thinking of people like us who are moving in and out of situations that involve some risk of HIV. So how to start and stop PrEP is a key question for our counselors. And one advantage of the on-demand dosing that was evaluated in the IPERGAY study is that it has the recommendation about how to start and stop PrEP built into the recommendation for PrEP. What they recommended was 2 tablets that should be taken 2 to 24 hours before sex, 1 tablet taken 24 hours after sex, and another tablet taken 48 hours after sex. And so this is on-demand dosing. And it was evaluated in a randomized placebo-controlled trial and shown to be highly effective. The risk reduction was 86% on an intention-to-treat basis. In fact, the 2 seroconversions that occurred in the active arm occurred among people who had stopped PrEP many months before they seroconverted. And so the as-treated analysis really showed complete protection. So this is known to be effective. Now, we were interested in seeing how feasible from a behavioral point of view on-demand dosing was, because we knew that it required planning for sex and recognizing when risky sex may have occurred. So the HPTN 067 was designed to evaluate this question of behavioral feasibility of non-daily regimens of PrEP directly. We randomized women, including trans women and men who have sex with men, to either receive a recommendation for daily oral Truvada use, time-driven use of emtricitabine tenofovir, which meant 1 tablet 2 times a week with a post-sex boost, and event-driven dosing involving 1 tablet pre-sex and 1 tablet post-sex. And they were followed for 24 weeks, and adherence was monitored with weekly telephone calls, as well as with a wise pill device that sends a message to our servers every time it is opened and a pill is taken. The study was conducted in New York City, in Bangkok, Thailand, and in Cape Town, South Africa. And this is data from the Thai site that involved men who have sex with men and transgender women. And what I display here is the proportion of the study cohort in the daily, time-driven, and event-driven arms who had detectable drug levels that we know are associated with more than a 90% reduction in HIV risk. And you can see that all 3 arms of the study were associated with very high proportions of study participants who were obtaining protective levels of drug. The daily arms and the time-driven arms did somewhat better than the event-driven arm, but proportions reaching protective levels of drug was high in all 3 arms. So I wanted to end with just to leave you with a concept of the cumulative power of choice. If we think of HIV exposure in our communities as being this red dot, condoms certainly decreased HIV risk in the 80s in the United States and later in other regions of the world. But not everyone uses condoms. And one approach, one aspiration is to try to make everyone use condoms. But we know that those 100% condom campaigns have had limited effectiveness. There's always going to be some people who just don't use condoms. So treatment came to the fore, and we know, again, that treatment is highly effective in decreasing transmission. And we also wish that everyone with HIV infection would accept treatment because it prolongs their life, it decreases their infectiousness, and it decreases their susceptibility to tuberculosis. And yet we know that there's a portion of people who do not get treated and do not stay on treatment. And while we strive to increase coverage of these 2 existing prevention modalities, we have PrEP. I think that one of the factors that led to San Francisco having such a dramatic benefit from its PrEP rollout has been that we already had treatment programs and testing programs and condom programs in place, such that the small hole left in our protective strategies could be filled by PrEP. So in conclusion, oral PrEP containing TDF is safe and effective. PrEP demand in the USA and now Thailand is at a tipping point, and there are social benefits of PrEP that are driving that demand. PrEP attracts people who will benefit the most from the intervention. PrEP use has scaled up massively in San Francisco, and after that there was a plummeting rate of HIV diagnosis. Behavioral safety is driven by belief in the future. On-demand dosing can guide how to start and stop PrEP through seasons of risk. And the PrEP development pipeline is full. I've just touched on a few of the concepts. There's many more in the pipeline, but for now, we have an effective approach that can be disseminated and used to control the epidemic because PrEP synergizes with other health interventions. PrEP is made possible by mostly young study participants who believe that research could improve their lives. Thank you.